Good evening, everyone, and welcome to the EUROGEN webinar programme. Just before we get started, I'd like to introduce a few words about the European reference networks, because not everybody knows much about them. EUROGEN is one of 24 European reference networks which cover all different medical fields. They were created by the European Commission in 2017, and they all deal with patients with rare diseases or complex conditions that require highly specialised healthcare. So the aim for us as a network is to try and deliver faster specialist evaluation and more equitable access to high quality diagnosis, treatment and care for those patients with rare urogenital diseases or complex conditions that need highly specialised surgery. So how do we work? Well, we collaborate using a clinical patient management system, which gives the experts within our network the ability to conduct a virtual European level MDT, enabling us to give specialist advice to doctors treating patients all over Europe without the patient needing to travel. We also collaborate on education and training activities, such as this webinar programme, and we also have a clinical exchange programme. Finally, we're also working on a EUROGEN registry, and it's very exciting that that's going live this year. So we'll be able to collect information from our now 70 healthcare providers from all over Europe. And of course, that should mean that we get some very interesting data quite quickly. Okay, without further ado, I would like to introduce our presenter this evening, Dr. Oscar Brouwer. He's an oncological urologist based at the Netherlands Cancer Institute. He's the clinical lead for penile and testicular MDT. He's chair of the EAU guidelines for penile cancer. And really, Oscar, I have to say you showed a high degree of resilience getting through the European Commission application process. But we're really delighted and honoured that your hospital is now finally in the network. And of course, we're also really pleased that you've agreed to lead the disease area for penile cancer for the ERN. So thanks very much, Oscar. It's going to be fascinating to hear from you about the sentinel node biopsies, why, when and how. So please, over to you.
Thank you, Michelle, for a kind introduction. It's a pleasure to be able to provide this webinar tonight, and I hope I can show you something about our experience with this procedure for penile cancer. And let's just start. I have no conflicts of interest for this presentation. And what I want to tell you tonight is, well, very shortly, something in general about penile cancer for the ones who do not know, and then quickly over to the sentinel node biopsy. Why would you do it? When would you do it? If you want to do it, how do you do it? Are there any new developments? And what's in store for the future? So about penile cancer, this is a reference network for rare diseases, so it's no surprise that penile cancer is one of the rare urological diseases. The incidence is, well, more or less on average 1 in every 100,000 inhabitants, but this differs a little bit throughout the world. For instance, you can see that in some countries in Africa, the incidence is quite higher in the figure here on the right. Well, I live in the Netherlands. I'm based in Amsterdam. And this incidence, the 1 in 100,000 for the Netherlands, this means around 150 new cases every year. But it's interesting to see that if you see this line throughout the years, it seems to be increasing. And it's a little bit unclear why. It's not only here, also you see similar trends in other countries, like this is a publication from Norway, where they also saw an average annual increase change of 0.8%. And interesting here is that they saw that the strongest increase is not in the older men, but more in the average aged men, as you can see in the figure here on the right. We also see the same trend here in our country, and it might be interesting to hypothesize why this is. I think HPV could play a role. Just short, 95% of penile cancers are squamous cell carcinoma. Around 50%, this also differs in every country, but on average around 50% are high risk HPV related. So how do the other ones come to be? Well, there are other risk factors like foreskin that does not retract, lichen sclerosis, chronic inflammation. These might be related, of course. If a patient presents himself with penile cancer, this is mostly on the glands or on the prepuce. I think this is a very important slide. This shows how, in terms of survival, the lymph node status is most important in penile cancer. This is the most important prognostic factor. On the left, you see the clinical end stage, so the lymph node stage, and on the right, the pathological. And you see as more lymph nodes are filled with metastasis, survival quickly drops. Why is this? This is one of the things that I think is well, more or less special in penile cancer. It's one of the tumors that mainly metastasizes throughout the lymphatic system. So actually, there are, in general, there's always an exception, of course, but in general, there are no patients that present with distant metastasis without having lymph node metastasis first. And the lymph node spread is pretty predictable. It's always to the inguinal zones first, and then if it passes further, it will go to the lymph nodes in the pelvis, and eventually, of course, it will go to distant sites. So here you see a figure where you see depicted that as long as the disease is only the primary tumor, 5-year survival rates are pretty good. You can mostly cure this disease, 90%. If there is metastasis in the inguinal regions, so the first station, so to speak, this is where the sentinel nodes lie, mostly you can still cure the patient, but more treatment will be needed. And if you see that, when you see that the disease progresses, so the lymph nodes progress to N2 or even N3 when it's in the pelvis, the survival rates quickly drop. And this is including all current treatments, multimodal, radiotherapy, chemotherapy, everything. So there's still a lot of progress to be made in this disease. So this is why would we do surgical staging? Well, I just showed you how the lymph node status is the most important prognostic factor. And these are two landmark publications, one from Kroon here from the Netherlands, another from Ornelas, that showed that resecting metastases in the lymph nodes of penile cancer early, so when they're not palpable yet or they're very small, versus resecting them when they become palpable at follow-up or surveillance, really effectuates in a big difference in cancer-specific survival. So in other words, detecting the lymph node metastasis at an early stage is crucial so that you have the chance to remove them at an early stage, which will be beneficial for survival. However, most patients that we see in the clinic, 80%, they present with clinically node-negative nodes. That means that you cannot palpate any node, and there's no suspicion of lymph node metastasis clinically. However, this does not mean that there are no metastases. If you look at, if you divide the patients in risk categories from intermediate risk and high risk, you can appreciate that still, even though you cannot palpate nodes, approximately 10 to 20% will still harbor small or occult metastases. So how to predict in more detail which of the patients are at risk? Well, unfortunately, there are no useful nomograms to predict exactly which patients are at risk. So that, no, it would be nice if we can do it with imaging. However, unfortunately, the imaging options that are currently available have too low sensitivity to identify small metastases or micrometastases in the groins. If you look at ultrasound, with a sensitivity of 39%, this is too low. Of course, the specificity is high. So that means if you find metastasis at ultrasound with a fine needle aspiration, then it's probably positive. But if you don't see anything, it doesn't mean there's nothing there. Same counts for CT or MRI with sensitivities of approximately 20 to 40%. And even novel techniques like PET-CT do not detect micrometastases reliably with only a sensitivity of 57% for the groin. And also there are false positives there when there is infection. So imaging will not really help us out here. And that's the reason why surgical staging still remains necessary for these patients. So which patients are we talking about? Well, if you look at the current guidelines, I already just showed you that the intermediate to high risk patients, they have a chance to 10 to 20% of having occult metastases. So the guidelines translate this to that in patients with T1 grade 2 disease or higher, it's recommended to do surgical staging. If you look at the guidelines, there's still several options they give. You can do either inguinal lymphadenectomy or dynamic sentinel node biopsy. And I hope to convince you all at the end of this presentation which one is superior for staging purposes. Firstly, let's look at inguinal lymphadenectomy, radical inguinal lymphadenectomy. This is a picture of how it looks like after performing it. You have several templates you can apply. But you can imagine when looking at that picture that this kind of surgery is associated with complications. We looked, it's a little bit older publication. We looked at a cohort of 270 patients from 2003 till 10, and we saw a total of 50 to 65% of complications. Wound infection being the biggest problem, but also lymphoceles, of course, skin necrosis, and more chronic problems like lymphedema occur frequently. And these can be a big problem for the patient. Of course, we live in 2020 or 2022 already, and everything is done by robot nowadays. So why not do the inguinal lymphadenectomy by robots? Probably then the complication will be way less. Well, unfortunately, this is also not really the case. We don't know yet for sure because it's all small series and it's mostly retrospective research, mostly single arm, so non-comparative. However, you see still, well, the numbers vary, but you still see quite some considerate complication rates. And this can be explained, of course, because you still remove all the nodes. So you still have a site where lymphoceles and infections can occur. Maybe the skin problems will be less, that seems the case. But lymphedema problems are not expected to change very much if you still remove all these nodes. So when looking at the other surgical staging options, I just spoke about radical inguinal lymph node dissection, 50 to 65% complications. Well, the benefit, of course, is that for staging purposes, it has the highest sensitivity by definition because you're removing all the nodes. However, if only 20% of the people have lymph node metastasis, then you're doing this treatment for nothing in 80% of patients. So quite some overtreatment there. I just showed the modified template. There you can see to the right, it's a little bit smaller field. This still has a good sensitivity, but of course you will have a small amount of false negative cases because you don't remove all the nodes. And the morbidity is a little bit less, but it's still considerable with 38 to 58%. And then the rest of this talk, I will focus on dynamic sentinel node biopsy. When looking at the sensitivity, the false negative rates differ. They seem to be lowest in high volume centers. The procedure can be performed in the same session of the primary tumor treatment, so the penile tumor, or you can do it secondary or delayed. I will delve into this deeper later on. But this means that there is time to refer these patients to reference centers if needed. And we're looking at the lower morbidity. I think you can appreciate that it's, of course, it also varies in different publications, but it's considerably lower when compared to lymphadenectomies. So for the ones who don't know, what is the sentinel node concept? Well, I already showed you the stepwise dissemination of lymph node metastasis and penile cancer. So first from the primary tumor, it will go to the first nodes, the first echelon nodes, or the first tumor draining nodes, and these are called the sentinel nodes. But this is depicted in this picture, and I think it's important to realize that it doesn't really mean that there's necessarily only one sentinel node. A tumor can have various lymphatic vessels leading to various first stations. So there can be various sentinel nodes, but afterwards it will lead to other nodes that are higher up, and these are called the higher echelon nodes. This is important to realize. Well, the sentinel node is supposed to be, that's the hypothesis, the first site of the nodal metastasis. So if you remove all the central nodes accurately, and they are checked by the pathologist accurately, and there's no metastasis, this should predict the status of this lymph node basin. This means that if you don't find the metastasis in a central node, you can spare the patient an unnecessary lymphadenectomy with the associated morbidity. Short little bit about history. It's not a very new procedure. Actually, it was a urologist from Paraguay named Ramon Cabañas in the 70s who already had a similar concept he developed. The only difference here is that he always postulated that the central node was located at the same location, medial to the superficial epigastric vein. So he did not account for variations in its anatomical location. And this led to unacceptable false negative rates, and the procedure was abandoned for quite some years. It was not until the 90s that the melanoma surgeons pioneered the traditional sentinel node biopsy as we know it today. And a few years after, for penile cancer, the procedure was introduced at the Netherlands Cancer Institute. I'm quite proud of that, by Professor Simon Hornblas in this publication you can see here. So how do you perform sentinel node biopsy? Well, the traditional procedure relies on the injection of a radiocolloid. So this is a radioactive tracer. You inject this around the tumor, or if the tumor is already removed, just proximal of the tumor, in 4 deposits in the skin, intracutaneous. Then the tracer will be transported by lymph drainage to the lymph node basins. And you want to visualize this dynamically, that's why they call it dynamic sentinel node biopsy, with lymphoscintigraphy. This is a gamma camera, and so the first, traditionally, scintigraphy is done continuously for 10 to 15 minutes. So hopefully you can see a lymphatic duct there, and you can see where the tracer leads to. However, there's not always early drainage. Sometimes it takes a little bit of time. So that's why we also do a static image at 30 minutes, a late image at 2 hours. And using this technique, you can visualize sentinel nodes bilaterally in up to 90% of patients. Also, this differs every study you see. So the visualization rates are quite high. On the right, you can see how this works. And this is an easy example where you see 2 sentinel nodes after 2 hours. And a little bit higher up, you see nodes coming up later on, probably in the pelvis, which are then deemed to be higher echelon nodes. You don't need to remove those. So I just said 80 to 90% visualization rates. What if you have non-visualization? So if you don't see any sentinel nodes coming up on the lymphoscintigraphy? Well, this is one of the publications from my colleagues from Asif in his group. They saw similar percentage, so in 10 to 12% no visualization, and they showed that repeating the procedure after a few weeks doesn't mean that it will be the same result. You can still have 86% of success of visualization. You could do something else. You could also do another re-injection immediately, or you could apply novel techniques such as SPECT-CT, which I will mention in more detail later on. On the right, you see a SPECT-CT, and I think this is something you should always be aware of when you have non-visualization on one side. The phenomenon that's called tumor blockage. A node might already be filled with tumor and therefore not accumulate tracer. You can see that on the CT scan in the right groin, and that might be the reason for the non-visualization. So be aware of that. So after visualizing the sentinel nodes on the preoperative imaging, patient goes to the OR. This can be the same or the next day. Both are possible. And in the OR, the procedure is mainly navigated using a gamma ray detection probe, which you see in the upper image. This measures the radioactivity. However, traditionally, there's also another extra injection applied, mostly at the beginning of the surgery, with a blue dye, which enables optical visualization of the sentinel node. So you can see the blue nodes coloring blue. One of the disadvantages might be that the rest also discolors blue. You can see that on the rest of the images. So this might be inconvenient for the rest of the penile surgery if the entire field is colored blue. This is the traditional procedure, and throughout the years, there has been some evolution in the procedure. Initially, the sensitivity was about 79% in the reports. And then the group, of Hornblas again, they introduced a couple of additional steps that luckily these modifications led to higher sensitivity rates. And these added steps, I marked them with a star, are performing ultrasound with a fine needle aspiration cytology if there's a suspicious node before surgery. So, for instance, one of those patients with tumor blockage could already be picked out using this technique and be treated with a lymphadenectomy sooner, which can also, of course, be beneficial. So if the ultrasound is okay, then you do the sentinel node biopsy, like I just described. However, at the end of the sentinel node biopsy, they introduced to also palpate the wound to see if there's any suspicious nodes. This also, again, is this tumor blockage phenomenon. And also, of course, to do meticulous scanning with the probe to make sure that you do not forget any sentinel nodes. And also pathology. If you don't make enough slices, a micrometastasis might be missed. So they updated the intervals for pathology. You can see that in the figure. And also this helped, I believe, to lower false negative rates. I just mentioned this shortly. Oh, no, I did not yet, I think. What I mentioned was that you can do it delayed, so after primary tumor treatment. But what in case of a recurrence? So you treated the penile tumor with organ-sparing surgery and the patient develops a recurrent tumor. Well, then we also showed that it's feasible, so it's possible to repeat the sentinel node biopsy for the new tumor, and you can still get high detection rates, and the false negative rates are comparable. However, there is a learning curve. It's difficult always when talking about these learning curves to establish how many procedures you have to do before you are proficient in it. Especially in a rare cancer like penile cancer, there have not been any studies really showing how the learning curve exactly is. But if you look at the sentinel node procedure for other tumors that are less rare, such as breast cancer, there are several studies that looked at this. And the recommendation is more or less between 20 or 40 procedures. And they have surgeons have a consensus that you should do more or less 20 of these procedures per year to be proficient in it. Gynecology also looked at it for their indications for sentinel nodes, and it's almost the same, about 40 procedures. So when looking at a rare cancer like penile cancer, to have 40 procedures in order to learn it and then to keep having 20 per year, this is not that easy for every hospital given the rareness of the disease. When looking at penile cancer, there is one meta-analysis that looked at 17 studies from different centers on sentinel node biopsy. They showed a pooled sensitivity for the procedure of 88%, but then they did a subgroup analysis for the high volume centers, and it did show a little bit better results. So just as a reference, our center last year, we did 85 sentinel node procedures because we're lucky. I think that in the Netherlands for many years now, there's a more or less regionalized or centralized care for these patients. So yeah, when talking about centralization, well, should the care of penile cancer be confined to centralized centers? Well, I don't want to delve too deep into this now, but there are some reports and there are some articles on this that suggest and maybe even show that centralizing care for these rare diseases leads to more penile sparing surgery. The pathologists see it more often, so better histopathology, greater use of techniques like sentinel node, MDTs. Of course, it will lead to more research possibilities, and research is needed to get new treatments, to find new treatments for the advanced cases that survival is still very poor. And at the end, we all want guidelines to change as well. And it's, at the end, it's all about the patient. So we want a better outcome. And maybe the centralization will help here. And otherwise, reference network, such as the one we are having this meeting with now, EUROGEN, might also have a role for other centers if they seek expert advice. So if you look at our experience, this is a publication that was published in our National Urology Journal in 2017. Like I said, we have a concentration of care. So there's one expert center, one reference center, that's the Netherlands Cancer Institute, and there are 3 other centers throughout the country strategically place throughout the country where some of the treatment can also take place. So we always believe that if it's possible, it's good for patients to have care close by home. But if it's necessary, then probably a referral to a reference center is best. And what we saw throughout the years is, in our center at least, that we have been performing more and more penile sparing surgery. Of course, I showed you that Professor Hornblas was able to introduce the sentinel node biopsy for this indication. Several PhDs were acquired, and at the end, I think we also want better outcomes. And if you look at this graph on the right, we did an analysis. This is important to realize that these are clinically node-negative patients, and then when you see throughout the years, the survival does improve. And we believe that the introduction, because you see quite some improvement around 94 and above, that this might be in part due to the introduction of sentinel node biopsy. So is there anything new on the horizon? Well, this is already quite some time ago, but it's not standard everywhere yet. The introduction of SPECT-CT next to the traditional lymphoscintigraphy. What it does, it has an increased sensitivity, so it's capable of detecting more nodes. So in case of non-visualization, in 10 to 35% of cases, you can still see something on SPECT-CT. This might prevent people from needing repeat or a secondary repeat sentinel node biopsy. Also, it can help, of course, because you get the third dimension, you get the CT scan, you can see exact anatomic location of the sentinel node. It can help differentiating inguinal from pelvic nodes, for instance. And also, it can help identify potentially pathologic nodes that did not pick up tracer. Again, the tumor blockage I spoke about earlier. So this is about imaging, but what about tracer development? Are there new tracers next to the traditional radiocolloid? Yes, there are some developments. This is an article from our friends and colleagues from the UK, showing a feasibility pilot with Sentimag, which is a superparamagnetic iron oxide particle. The possible pros are that it's not radioactive, so this might be convenient in some countries that have problems with regulations in that behalf. They showed it in 9 patients, and the concordance compared to the traditional radiocolloid, because these patients got both tracers, was 100%. So it seems like it identifies the same sentinel node. So this is good. However, I wonder if it will at the end replace the radiocolloid. I have a few questions in that sense, that since you do not have the dynamic lymphoscintigraphy, you only have the opportunity to do MRI before operation to identify the nodes on a scan, and this will only be one set time point. So this might lead to seeing a lot of nodes light up and not knowing exactly which was the first coming up. Also, of course, in terms of costs and oncological safety, there are no reports yet. It's just too new, so we need more research on this, and we're looking forward to seeing more. Another part of the talk, I want to shortly introduce other novel techniques such as fluorescence imaging, such as the tracer ICG in the sign in green. Many of you will already have heard of this. Just in short, if you look at the difference between techniques like radioactive guidance and fluorescence guidance, I think it's important to realize that while fluorescence is nice because you can see the target lesions, the resolution is very high, that's good, but the tissue penetration is low, below 1 centimeter, compared to radio guidance, where it's above 10 centimeters. This means you can only see the nodes at the very end before excision. A little bit sooner than blue maybe, but still at the last moment. So here I try to summarize the strengths of both fluorescence, but also the limitations. And I think if you look at fluorescence alone, this might be a problem if the targets are deeper than 1 centimeter. And of course, obesity is also an increasing problem throughout the world, especially in the Western world. So I fear that fluorescence alone will not be a possible replacement for the radioactive compounds. However, if you can combine them, maybe you would get a best of both worlds scenario. So this is what the group of Vijs van Leeuwen from Leiden did already 10 years ago. They combined the traditional radiocolloid, technetium nanocolloid, with indocyanine green in one tracer, so one injection, so-called hybrid tracer. And well, throughout the years, we've been using this tracer in several sentinel node applications, not only penile cancer. So there's a lot of experience with it now, already more than, I think now it's already almost 2,000 patients. So what I'd like to do is show our experience, our 10-year experience with this tracer for penile cancer. This is something we just recently published a year ago in the Platinum Journal. So what did we do? The study describes 400 patients, so in total 740 groins, with an indication for sentinel node biopsy. They all received this hybrid tracer, so high ICG technetium nanocolloid. They all got their traditional lymphoscintigraphy followed by SPECT-CT, because at our center all patients get SPECT-CT. And then during surgery, we used both techniques, which you can appreciate here, the gamma probe in B, but also a portable gamma camera to visualize a static image of the radioactivity, and a fluorescence camera to visualize the fluorescence imaging. So just in short, firstly, what did we see before the operation? Well, pretty good visualization rates with 92% only on lymphoscintigraphy, but the addition of SPECT-CT gave us almost 100% visualization rates using this tracer and using SPECT-CT. During surgery, the vast majority of patients also got a separate injection of blue dye. This enabled us to compare both tracers. And there was a big difference. So when looking at the optical identification of the sentinel nodes with ICG versus blue dye, we could see 95% of nodes colored green and only 56% of the nodes colored blue. And importantly, when looking at the tumor positive nodes, 16% of them were not blue. So I think this is clear evidence that it outperforms blue dye in that sense. In total, we followed the patients up for a median of 36 months, and out of the 740 groins, we only had 8 false negative procedures, leading to a diagnostic accuracy of 99%. If you calculate the false negative rate, which of course highly depends on the amount of positive events, we saw a false negative rate of 8.7%, with a probability of a negative procedure to become a false negative at 2 years of 1.4%. This is a short video showing the procedure where in a patient where we saw 2 sentinel nodes in the groins. Here you can see the gamma imaging we do at forehand. This enables us to compare it after excision and show that all the nodes are gone. And here you see a node that's not blue, but you can clearly see it with the fluorescence camera through the fat. And at the end, after excision, we show that the node is both radioactive and fluorescent. And after excision, we make a new scan with the gamma camera, and then we can see that all the activity is gone, confirming that we removed the sentinel nodes. This is just a short summary showing the evolution of the procedure, which I already showed in the previous slides. But the question is, well, we're in 2022 now, is there still room for improvement? I believe so. We just recently did an evaluation of complication rates. This is currently unpublished data, but it's submitted by one of our students, Lieke Wever. We analyzed 644 patients, so this adds up to 1,284 groins in which a sentinel node procedure was performed. And in total, we saw a complication rate of 14%. Of course, this is way lower than lymphadenectomy, which I showed previously, but it's still considerable. When you look at the type of complication, it's mostly wound infections and lymphoceles, and luckily, the vast majority is minor, grade 1 to 2. However, I think there's still some room for improvement, and to evaluate this, we looked at risk factors. So you might say maybe diabetes or BMI might be a risk factor, but in our analysis, it was not really the case. The only real significant risk factor for complication was the number of removed lymph nodes, which you can see marked in red. Here it's visualized in a graph. The more nodes you remove, the more complications. So this is, of course, it seems logical, because the more nodes you remove, the closer you go to a radical lymphadenectomy. And we all know this is associated with many complications. But the challenge is, okay, so are we removing too many nodes with the sentinel node biopsy? Well, I think if you look at this image, sometimes yes, sometimes we do remove almost 4 or 5 nodes per groin because so many nodes are radioactive. But are they all true sentinel nodes? Well, that's the question, I think. How can we reduce the number of these nodes that we remove? Of course, while also being as accurate as we are and not having any compromise in terms of false negative rates. Well, I think maybe new technologies like SPECT-CT or other time points of lymphoscintigraphy might help to better distinguish which is the first tumor draining node. And if you look at during surgery, we also see that the surgeon sends in a certain number of sentinel nodes. You can see that above. But then when at the end, every step, it turns out to be more nodes. The pathologist finds way more nodes in the specimens. So maybe also during surgery, if we can develop techniques to more accurately remove only the sentinel node and not unnecessary surrounding tissue with possible small nodes in it, this might also lead to an improvement. And maybe techniques like fluorescence imaging or novel tracers can have a role here. But this is all topic for ongoing research, so we're not there yet. So this already brings me to my conclusions. I hope I showed that lymph node status is decisive for survival for these patients. And if you cannot see clinically small metastases with imaging, then invasive staging will still be indicated in patients that are intermediate to high risk, so everything T1, grade 2 or above. Of course, it's a balancing act. If you do surgical staging, you want to optimize the diagnostic accuracy because you don't want to be wrong in predicting if there are sentinel nodes, if there are metastases. However, you also want to minimize the morbidity. And when comparing radical lymphadenectomy, modified lymphadenectomy, robotic lymphadenectomy with sentinel nodes, I hope I convinced you all that when looking at this balancing act, the current winner is dynamic sentinel node biopsy. However, if you do it, you have to do it correctly. So there is a learning curve involved. And the numbers seem a little bit better in high volume centers. So this might be a reason for centralization, but that's something that's up for discussion. And I hope to see more evidence on that in the future. I hope I showed that the most important risk factor for these complications is the number of removed lymph nodes. So we should try and operate as accurately as possible. However, we can only be accurate if we remove all true sentinel nodes. So this is the top priority. And I believe that we should first do further research to see if we can safely, more precisely remove only the true sentinel nodes, so less nodes, in the hope that we can reduce the morbidity for these patients even further. So with this, I would like to close. I really hope that EAU 22 in March this year will be a live meeting and not a virtual meeting. In case it's live, I would like to, of course, invite you all. We are planning a few days before the Congress to do some demonstrations on this sentinel node biopsy technique in our hospital. So if you're interested in visiting our clinic, which is also in Amsterdam, so it's really close, then just get in touch with Michelle and they can get in touch with me, and then we can organize a visit. That's no problem at all. So with that, I'd like to close, and I will take some questions if there are any. And I thank you for your attention.
Thank you very much. If you have any questions, you can type them in the question field. Oscar, we do already have 2 questions. I sent them over to you.
Yeah, so I see one from Mariah Punda asking how many procedures should be performed. I think maybe the question was asked before I showed it in the slide. We don't really know exactly because it's just a rare disease, so we don't have any hard evidence on this. But if you take other sentinel node biopsies as a reference, 20 to 40 is what the current consensus is. I see a second question there. Do you have experience in cases where your sentinel node is not located in the groin, but under the fascia of the externus abdominis muscle? What would you do in that case? Well, in the vast majority, the sentinel lymph node will be in the groin. However, sometimes people have had, for instance, previous surgery. It could be a repeat sentinel node because of a recurrence, but it can also be an inguinal hernia or some other surgery, or as a child maybe, or some testicular surgery. And sometimes we see aberrant drainage, so as we call it, and mostly we see it direct drainage to the pelvis. However, if we encounter something like this, we mostly choose, of course, it all depends on the patient and the age and the morbidity, and of course also the risk of the tumor, but mostly we would decide not to do the sentinel node biopsy if it means doing pelvic exploration. Then mostly we will go for surveillance if possible, or well, you could do a modified lymphadenectomy, but then you can also wonder how accurate that will be if there is aberrant drainage. So I think these patients should be, in any case, very closely monitored if they have a high-risk tumor. One other question: do you perform fine needle biopsies? Yes, I hope I showed it in one of the slides that we saw, that's our experience, that false negative rates improved once all patients that have an indication for surgical staging, they all undergo ultrasound by the radiologist, but in our case. And if they see suspicious nodes, they immediately get a fine needle aspiration cytology. They actually already get this the first day when they come at the hospital. So we have this, we call it diagnosis street, where they come to the hospital and they get everything in one day. So the next time they come to the hospital, it's actually already the surgery. And this is convenient because patients of course come from all over the place in the country. So that way they don't have to travel that often. Do you repeat the fine needle aspiration cytology in men with clinically node positive and negative fine needle aspiration? Well, yes. So if we have a suspicion of nodes, for instance, they're palpable, or the ultrasound already says that they think it's a suspicious node, but the pathology of the cytology is negative, then we repeat it at least once. Should local recurrence always trigger repeat sentinel nodes? Well, this is a good question from Maarten Albers, I see. The question is, of course, if local recurrence behaves more aggressively than a primary tumor. There have been some different reports on this. We always thought that it wasn't the case, but some new reports suggest that it might be the case. So in the current guidelines, it's not really recommended to always do sentinel node in any local recurrence. It's still recommended to do it T1 grade 2 or higher, but this could be something to look up or to do research on in the future. Do you only perform fine needle cytology as a screening tool to scan multiple lymph nodes, or just the suspicious one? So yes, it's not screening. If the lymph nodes are totally normal by palpation and also during the ultrasound, we will not do a cytological punction. Which is better, fine needle or true cut? Well, fine needle definitely has the lowest morbidity, and it's very easily possible in the outpatient clinic, and also if patients have anticoagulants. And because we are going to do a sentinel node anyways, I think in that case, that's the reason why we always choose to do fine needle. almost there through the questions. 2 more. Do you use the frozen section analysis and perform radical lymph node dissection at the same time? It's a good question. So I think the question is during surgery, do you do a frozen section analysis so that you don't have any delay? So if you have a metastasis, then immediately you can do the dissection in the same session. Well, we don't. I know that some centers in the UK sometimes do it. The reason why we don't do it is because we're talking about micrometastasis here. It's already a clinically node negative patient. So the chances of finding this at the fine needle, at frozen section analysis are not that high. I think the chance of false negative is quite substantial. And on the other hand, you also want to have that node for serial sectioning. So we do not do it. And luckily, if we have a positive node and we want to do a secondary completion lymphadenectomy, we can almost always do this within 4 weeks. So we don't really have the need to do this. Last one, what do you do if the ultrasound is abnormal, but the fine needle is negative? I think already one of the previous questions I answered that. We repeat the fine needle at least once, maybe even twice. And if it remains negative, then we'll just do the central node. Of course, if there's a clear palpable node, you could also consider doing CT or PET imaging. But we are talking about clinically node negative patients here. So I think, oh, one more, so if there's still time. How do you treat men with clinically node positive but negative fine needle aspiration cytology? So I noticed there's quite some questions about this because it's in line with the previous question, but there's a little bit difference here. The clinically node positive is the question. So I think the Christian means if you palpate a node. Well, I'm very curious, for one, what the real value is of palpation of the lymph nodes now that we live in 2022, and if every patient gets the ultrasound. I think that sometimes if there's inflammation or infection, you can also palpate the node. And of course, in obese patients, you won't palpate anything, but there might be something. So I really wonder what the real clinical value is nowadays in the current time of palpation. That said, of course, we still palpate all our patients. And if there's a high suspicion, but the cytology is negative, then I mostly go to the radiologist and I ask them, what did you see? And we look at the ultrasound together. And was it a necrotic node, or were there any signs of metastasis? And if the node is also suspicious at ultrasound, yeah, then we'll definitely repeat the investigations or make sure that we remove that node during the sentinel node biopsy as well. So I think with that question, we have come to an end of the questions. I hope I answered them well enough. Otherwise, you can get in touch via email and we can have a discussion about it. I wish you all
Oscar, thank you very much. Yeah, thank you for the interesting presentation. Thank you all for joining today. And this webinar has been recorded and will be available on both our GoToWebinar platform and the YouTube channel, for which I will send the links tomorrow. And all previous sessions are available on our website, as are the details of the forthcoming webinars. You will all receive a survey immediately after the session, and we would be very grateful if you could spend a few minutes to fill it in so we can continuously improve our further sessions. So I'd like to wish you all a very good evening and see you next time. Thank you very much.
Bye, everyone.